all, as the Director of Operations for the Healthcare Local Area Partnership, I'll be presenting on the topic, the effect of primary healthcare shortage at Hertfordshire County. So the overview of my presentation is going to be centered primarily about the primary healthcare shortage in Hertfordshire, which you understood that is a system-wide operational issue, not simply a workforce gap. So we are seeing increasing demand driven by population health needs combined with workforce pressure and financial constraint. And from operational perspective, this is creating reduced service capacity, delays in patient access, and declining public health in public trust in healthcare service. So the key operational challenges that I have noticed from my own department is there is a demand capacity imbalance where the GP workload continues to exceed safe and sustainable levels. There is workforce burnout and high turnover. There is also fragmented service delivery. And also there is a declining patient trust and engagement with increasing concern around access and service quality. So to mitigate the theoretical approach or the leadership role I'm going to use to address this is the system leadership, whereby I will recognize the primary care challenges that cannot be solved in isolation, and as they are directed, they are directly impacting wider system performance. I'll make use of transformational leadership, which is essential in driving change and motivating staff. I'll make use of Kotter's challenge model, which provides a structured framework for implementing sustainable operational improvement, and compassionate leadership, which is critical in addressing workforce burnout through engagement, listening, and psychological safety. So the strategic interventions which I will make use of is, first of all, I'll make use of what I call digital tirage and hybrid access model. What it simply means is that patients need to give us their information and symptoms online, digitally, before coming to GPs or hospitals. We're also going to have a integrated care pathway across sectors. We're going to make use of multidisciplinary workforce models to reduce reliance on GPs by expanding roles such as pharmacists and nursing practitioners. I'm going to finally do what they call community-based prevention and early intervention to reduce long-term demand and improve population healthcare outcomes. There are risks that we need to mitigate. Due to the digital tirage, there's going to be a digital transformation which will lead to exclusion of vulnerable populations because everybody is not tech savvy. Secondly, the service integration may face organizational resistance due to different priorities across sectors. We are going to see that the risk of short-term disruption. There is going to be something called the capacity pressure in the short term, and a phased and carefully managed implementation approach will also be addressed. So in conclusion, the primary healthcare shortage presents a system-level operational crisis, not simply a workforce issue. So addressing this requires integrated strategic and compassionate leadership across the clear focus of system redesign. So the goal is to stabilize access, improve efficiency, and restore public trust. So without intervention, these challenges will continue to escalate, which we don't want, and increasing pressure across the entire healthcare system. So my colleague will be presenting the next topic under this.
Good morning, everyone. I'm Jayashree Harnidani Kumar, and I'm the Hertfordshire Council Program Manager. I'm here to present our recommendations to the Healthcare Working Group on addressing the contemporary challenges affecting primary healthcare across Hertfordshire community. Moving on to the Hertfordshire healthcare landscape. Hertfordshire serves a population of 1.6 million residents who face a stark social gradient in health. The most deprived communities spend up to 18 years longer in poor health. Primary care acts as a front door, but demanding is spiraling beyond our current capacity, threatening the continuity of care that our communities have relied on for decades. The contemporary healthcare challenges are workforce burnout, spiraling demand, and health inequalities. Next slide. To respond to these challenges, the Health and Care Act 2022 puts collaboration on a statutory footing, helping us transition from competition to integration through integrated care boards. This key impact allows us to share resources across primary care networks to maintain services that would otherwise face closure at a single practice level. Next slide, please. Coming to the culture of innovation, to survive, we must shift from a reactive to a proactive approach, where innovation is treated as a mindset shift towards anticipatory health rather than just technology. We are implementing integrated neighborhood teams and over 500 virtual ward beds to provide expert care directly at home and reduce the hospital dependency. Next slide, please. This is a service prioritization framework. The service areas that we are covering are routine GP access, which can be mitigated by digital triage and pharmacy first approach. Chronic care can be mitigated by integrated neighborhood teams. Minor injury units can be mitigated by consolidation into hubs. And finally, the home visiting services can be mitigated by virtual wards in community nursing. Applying these strategic frameworks and recommendations. Here, we have applied the McKinsey 7S model to align our strategy for resilience. Our strategy aligns with the 2024-25 NHS planning guidance, keeping a strong focus on productivity and recovery. We utilize a human-centered One Hertfordshire approach based on the Marmot principle to ensure there is no community left behind. Following the HRM principles of Banfield and Cape, we are focusing on retention through resilience building and psychosocial support. Next slide. Addressing the social determinants. As per the Marmot Review 2020, our strategy must look beyond clinical walls to prioritize primary care resources in areas of high deprivation. So my recommendation would be shifting funds towards a preventive outreach in Broxburn and Stevenage pockets to reduce a long-term hospital pressure. Next slide. Moving on to the prediction of unforeseen challenges. While these actions are designed to improve efficiency, a rapid shift in resources may introduce unforeseen operational and workforce challenges. To respond to this, we will support staff with the necessary frameworks to foster resilience and reduce turnover. So my leadership recommendations would be shifting the fund towards a preventative outreach in pockets of high deprivation, such as the Broxburn and Stevenage, to reduce long-term hospital pressures. Fully delegate ICB responsibilities to health and care partnerships to localize the decision-making. And continue virtual ward expansion to release 10% of physical capacity by 2026. Mandate quality and equality impact assessments for all financial decisions to ensure equity of access. Thank you all for your time and for helping us to ensure a healthy, green and sustainable Hertfordshire to all. Thank you. Now Rose will be presenting.
The mic is muted.
Rose, can you please unmute your mic?
Good day, everyone. My name is Rosemary Chibuzo Amadike. I'm the Clinical Director for the Hertfordshire Local Area Partnership. My role is to ensure safe, effective, and I will start again, sorry. Good day, everyone. My name is Rosemary Chibuz Amadike. I'm the Clinical Director for the Hertfordshire Local Area Partnership. My role is to ensure safe, effective, and high-quality patient care while supporting clinical staff and maintaining service delivery. As a clinical director, I focus on patient safety, staff well-being, and improving clinical outcomes across healthcare services. So now I'm going to look at the current clinical situations which the Hertfordshire is facing now. There is high demand for GP appointments, nursing care, and community health support, but not enough trained staff to meet this demand. Because of all this, it causes delays, unsafe workloads, and reduced patient trust. Patients may wait longer for treatment, which can also lead to worsening health condition. Next slide. A major challenge A major challenge is high staff turnover among nurses and carers. When experienced staff leave, remaining staff become overworked, leading to burnout, low morale, and poor patient outcomes. This also increases the use of agency staff, which raises cost and reduces continuity of care. There is also shortage of trained staff in preventive services such as diabetic care and smoking cessations. These services are important because prevention reduces future hospital admissions and long-term costs. Without strong preventive care, hospital faces even greater pressure. Now, to address this, I'm going to look at the leadership framework. And I also applied transformational leadership because one, it helps motivate staff, improve morale, and support positive change during difficult periods. It allows leaders to create a clear vision and encourage teamwork across departments. I would also use compassionate leadership by supporting staff well-being through listening, empathy, and emotional support. Because when staff feel valued, retention improves and patient care becomes safer. This also creates a healthier working environment. Now, I'll go to one of my recommendations, which is a strong staff retention strategy, including flexible shifts, mentoring, well-being support, and leadership development. Investing in staff helps reduce turnover and improves long-term service stability. I would also protect preventive services and improve patients' feedback system to rebuild trust and increase service use. Listening to patients helps services improve and strengthens public confidence. And now, in conclusion to all this, primary healthcare shortage is not only a staffing issue but also a patient safety issue. Strong leadership, workforce stability, and preventive care are essential for healthcare and more successful healthcare community. Thank you.
Good morning, all the board members. I am presenting today in my role as a HR manager for the Hertfordshire Local Area Partnership. The NHS and social care workforce crisis is not a future risk. It is happening right now and it is affecting our ability to deliver safe, quality care across the region. Across England, there are over 112,000 NHS vacancies in our own care home sector. Annual turnover exceeds 30%. The average cost of replacing just one nurse stands at £8,300, and we cannot afford to keep absorbing the cost without acting strategically. The next slide, please. So I'm talking about the root causes. The next slide, please. So I'm talking about the root causes and let us know why this is happening. My analysis grounded in Banfield and Kay and identifies four interconnected root causes. One is compensation erosion, that real terms pays cuts as inflation outspaces NHS pay awards. The second one is workload burnout, post-pandemic psychological burden and chronic understaffing. The third one is pipeline failure, inadequate investment in apprenticeships and succession planning. The fourth one is cultural dysfunction, low trust, low recognition environments that drive attrition. The next slide, please. So I'm talking about the legislative and policies. In 2022, we got the Health and Care Act, and 2023 NHS Long-Term Workforce Plan. In 2020 and 2021, NHS People Plan, and 2010 was Equality. So the next slide, please. So I would like to talk about the three recommendations. The recommendation one is the targeted retention strategy, which is immediate and it can be done in 0 to 6 months. We will introduce the Hertfordshire Healthcare Retention Premium, a locally funded supplement for staff with 2+ years tenure in shortage roles. Alongside this, we can will implement mandatory quarterly well-being audits in council-run care homes, co-design flexible working patterns in line with the NHS People and Staff Recognition Program, Banfield and K confirm retention in 3 to 4 times more cost-effective than replacement. The recommendation two. Next slide, please. So the recommendation two is diversified recruitment pipeline. It can be done between the short and medium term, which is of 6 to 18 months. As a sustainable workforce cannot rely on a single supply channel, we will build four streams: academic partnership with universities and ethical international recruitment aligned with NHS guidelines. And the third one is a grow your own community initiative targeting undeserved Hertfordshire communities and men's health workforce strand to address gender imbalance in caring roles and improving service uptake for men. So the next slide, please. The recommendation three is culture change and continuous development, which is of long term 12 to 36 months, drawing on Deal and Kennedy and Gilbert's compassionate leadership framework. We will commission a county-wide cultural health assessment, implement anonymous staff feedback systems, co-produce recognition frameworks with frontline staff, and embed continuing professional development as a structural entitlement, not a discretionary benefit. Culture change cannot be mandated, it must be co-constructed. And the next slide, please. So the risk analysis are financial risk, equity risk, and the dependency risk and change fatigue. So I'll move on to the next slide, which is call to action, and that would be the conclusion. So board members, Hertfordshire deserves and can achieve a healthcare workforce that is resilient, valued, and sustained. I'm asking this board to approve three actions. The first one is retain, deploy a targeted retention strategy immediately. Recruit is the second one. Build a diversified, locally anchored pipeline. And the third one is reform. Invest in the cultural and developmental infrastructure that makes Hertfordshire a place people choose to work. These three strands form a coherent, integrated people strategy for Hertfordshire. I commend them to this board. Thank you. Next presentation is going to deal by Sunita. Thank you.
Good morning, all. My name is Sunita Arwa, Program Manager, Hertfordshire Centre Hospital Trust. So today I'll be discussing the impact of primary healthcare shortages across the Hertfordshire community and how this is affecting the wider healthcare system. So, current system pressure. Currently, the shortage is primary healthcare is creating significant pressure across the system. We are seeing more patients attending A&E with conditions that could have been managed within a primary care. This is leading to overcrowding, longer waiting times, and delay in treatments. At the same time, community services are becoming overstretched as they are managing more complex patients needed. Without significant support, this shows how pressure in one part of system includes the entire healthcare pathway. Next, system-wide impact. From a system-wide perspective, these challenges are interconnected and far-reaching. Limited access to GP services is leading to increased hospital admission, delayed discharges, and reduced continuity of care. This creates a cycle of pressure across the system. In addition, workforce challenges such as staff shortages and burnout are reducing the system's ability to respond efficiently. Next slide. Workforce and capacity challenges. Next slide, please. Thank you. A key issue within the challenge is workforce and capacity. Shortages in primary care staff, including GPs and nurses, are limiting appointment availability and increasing workload for existing staff. This is contributing to burnout, reduced morale, and lower retention rates. From a program management perspective, this creates a significant risk to service sustainability. Without addressing workforce capacity, it becomes difficult to improve access, maintain quality of care, or implement long term system improvements. Next slide. Leadership and strategic approach. Addressing this challenge requires a strong leadership and strategic approach. This includes compassionate leadership, where we listen to staff, support their well being, and understand future pressures. At the same time, system leadership is essential to ensure collaboration across primary care, community services, and hospital settings. Using strategic framework allows us to analyze both internal challenges such as workforce limitation and external pressures, ensuring that our response is informed, coordinated, and sustainable. Next slide. Program level priorities. Several priorities must be addressed. Strengthening integration between services is critical. Improving patient flow and reducing unnecessary hospital demand. Workforce sustainability must be prioritized to staff support, retention strategies, and flexible working models. In addition, service redesign is needed to improve efficiency and ensure patients are treated in the most appropriate setting. Digital solution can also support improved access and communication across services. Next slide. Understanding the ecosystem. It is important to understand that the healthcare system operates as a connected ecosystem. Changes in primary care directly affect community services, hospitals, and social care. A lack of coordination can lead to inefficiency and increased pressure across the system. Therefore, a whole system approach is required where all parts of the healthcare system work collaboratively. This ensures these solutions are addressed root causes rather than just managing systems. Measuring impact and collaboration. Next slide. To ensure success, it is important to measure outcomes efficiently. This includes reducing accident emergency attendance, improving access to primary care, and enhancing staff satisfaction. Ongoing monitoring and data analysis will support continuous improvement. Collaboration is also essential with strong partnership between healthcare providers, local authorities, and community services. A coordinated approach will ensure that improvement are both efficiency and sustainability. Overall, addressing primary healthcare shortage requires a coordinated, system-wide approach that focuses on leadership, workforce sustainability, and integrity care. Thank you all. So now, my next colleague, who's Ahmad Raza, is going to present.
Good morning, everyone. My name is Ahmed Raza, County Council Lead Member of Hertfordshire County Council. I just introduce my role in Hertfordshire County Council. Next slide, please. Representing Hertfordshire County Council in a health strategy meeting, concentrate on public health, well-being, present and health disparities, ensure cooperation among NHS and local authorities in community service, foster counter and sustainable healthcare planning. Next slide, please. Healthcare challenges in Hertfordshire County Council that are mentioned: staff shortage and bound in rural workplace, increased healthcare need and economic stress, unequal health and among vulnerable communities, failure in communication and partnership among the organizations. Next slide, please. Transformation leadership that leads develop a common vision and drive change, promotes creativity and teamwork, address healthcare reform in the long term. noteworthy in respect of integrity, care system, and multiple agencies work. Next slide, please. Compensation leadership. Based on proof through Gilbert leadership presentation, emphasis active listening, presence, empathy, and reflect practice, improve staff well-being and psychological safety. Better staff support can improve patient outcome and retention. My recommendation is 10 staff well-being program, increase investment community and prevention healthcare, improve integrity communication system, enhance stakeholder engagement and partnership agreements, support evidence-based. Reverse slide, please. This support evidence-based and compensation decision making. Next slide, please. Risk and unauthentic convenience. Short-term financial costs may increase. Resistance to organization change is possible. Benefit from prevention strategy may take time. Need to balance operation pressure with patient care. Next slide. And at the end, a conclusion, effect healthcare leadership requires collaboration, compression, transformational system. Leadership can support sustainability, compression, leader improve organization culture. Long-term public health improvement should remain the central goal. Thank you, everyone.
Thank you very much for your nice presentation. Now,
Okay, so
Yes,
let's
please.
move on to the discussion. I'll just pose my first question to Mr. Ejiofor. So,
okay.
what would be your first priority if you had to act immediately?
Yeah, from a director of operation perspective, my first priority is nothing but I will try to redesign the access to primary health care for everybody, particularly through the TIREAD system. And what I mean by TIREAD system is making use of the digital platform where patients will have to give out their details, their symptoms, whatever they are feeling digitally before they will now come into the hospital if need be. This will deliver an immediate impact by improving patient flow, reducing pressure on GPs, preventing unnecessary escalation into the secondary care. So I believe if I do this and make it a priority, it's going to go a long way. Yeah.
Thank you, Ejiofor.
Yeah. Sumita, we cannot hear you.
Sorry. Why is primary care the priority instead of hospital services?
Oh, okay. I think you are directing that question to me, correct? Yeah.
Yes.
From an operational perspective, once again, the primary care is the entry point, the first point of call to the healthcare system. So as a result of that, if we don't stabilize it, demand will continue to do what? Escalate the downstream into the hospitals, increasing the cost and the pressure. So by prioritizing this primary care, we are addressing the issue upstream, which has the greatest system-wide impact. So we know that we need to tackle it first, then before we now move to other services. Yeah. Thank you very much. I believe this is clear now.
Jayashree, I have a question for you.
Yes, please.
Give financial constraint, how do we ensure the shifting resources to different areas doesn't create a postcode lottery where other communities lose out?
Thank you for the question, Sunita. To prevent a postcode lottery, our strategy relies on integrated resources rather than a zero-sum reallocation. We will mandate quality and equality impact assessments for all financial decisions that we are going to make. And under the Health and Care Act 2022, we are moving from a competitive model to an integrated one. This will allow primary care networks to share resources rather than isolating funding at individual practices. By utilizing the Marmot principle, we prioritize high deprivation areas to reduce the long-term strain on acute hospitals. This ensures that we support our most vulnerable communities while maintaining overall service stability.
Yeah, I
really
have
interesting.
another question to you, Jayashree. Let me ask a question to Jayashree, which I want to clarify on that. So you mentioned that virtual wards will release 10% of physical hospital capacity by 2026, right? Is this a realistic target given the current digital divide in our older population?
Yes, it is a bold target, but we are approaching it with a human-centered strategy rather than just a technical one. We are not just giving out tablets. Our integrated neighborhood teams will provide a physical expert support that is needed to bridge the digital gap. By using 500 virtual beds, we provide expert care in a familiar home environment, which research shows actually improves the recovery for the geriatric patients. Following the Health and Care Act 2022, we are pooling digital resources across the country to ensure no patient is left behind regardless of their tech savviness. This isn't just about the technology, it's about scaling the mindset shift towards anticipatory health. I hope this answers your question, Monica.
Thank you. Thank you so much.
Yeah, you are quite detailed. And I want to ask Rosemary a question because in anything we are doing, if there is no funding, I don't know how it's going to function. So, Rosemary, I want to ask, what will you do if funding is limited?
If funding is
Yeah,
limited.
I think you're muted. Yeah.
Can you hear me now? Okay. What I will do if funding is limited is I will prioritize service based on patient safety and long-term value. Also, essential preventive services will come first, and then retaining experienced staff is also cheaper than repeated recruitment and agency cost.
Okay. Can I see your point that you don't have to throw away and start
Yeah.
getting retain the new, the
Staffs,
older
yeah.
ones, then that will go a long way in maintaining costs. But what if the staff resist these changes that you are trying to propagate?
Then, if the staff resist the changes, I would involve staff early. I will communicate clearly and explain the benefit of change. And also, as a compassionate leader, I will also help the staff feel heard and supported because because they are more likely to accept change because as their director. Yeah.
That's lovely. Yeah. I
Hello,
noticed everyone was making mention of transformational leadership. I made use of it. Maybe
Sorry,
maybe
guys. Actually,
Jayashree can or Monica and give me her view what she means by, because I know everybody have it in mind, even if you don't mention it.
sorry,
Is
guys.
it Jayashree that mentioned it or Sunita? I've forgotten.
that's for me.
Oh, Rosemary. Okay, Rosemary. Why do you want to make use of transformational leadership?
I chose transformational leadership because staffs are facing burnouts, low morale, and high turnover. And because of is off. Oh shit. You guys want something? Okay. I chose transformational leadership because staff are facing burnouts, low morale, and high turnover. Because of this, they also need motivation, support, and clear direction because this leadership style improves engagement, staff retention, and patient care quality. Yep, that's what I chose.
Do any other person have any other?
So I have a question for Monica.
Yeah.
Yeah.
Yes, please.
Culture change programs often fail. What makes you confident this approach will be different, and how will you measure success?
Thank you for the question. You are absolutely right to be skeptical. The literature is full of failed culture change initiatives. According to the Zabri 2018, is explicit. Culture change cannot be mandated. It must be co-constructed, as I mentioned during my presentation, through genuinely sustained dialogue between the management and the frontline staff. Our approach is different in three ways. We are not imposing a culture program from the top. We are commissioning a county-wide culture health assessment first, listening before acting. And the second one is anonymous staff feedback systems will ensure psychologically safety with which identifies as a prerequisite for organizational learning. I'm sorry. Success will be measured through concrete what is that? Sorry, concentrate HR metrics, staff turnover rates, vacancy full times, absence rates, and staff survey scores, all reported quarterly to the HLAP board for public accountability.
That's lovely.
Is that
Can I-
answers your question?
Okay.
So
I don't know.
Yeah,
Can I
thank
ask
you.
question more? I think Rosemary wants to say something. Sorry.
Yes.
Monica, I have a question for you.
Yes, please.
How will they grow your own community initiative? Sorry, how will they grow your own community initiative actually work in practice? And how do we ensure it doesn't simply create a pipeline of low-paid, undervalued workers?
That was a good question, and thank you. That is a crucial safeguard question, and one I have built into the design. The initiative targets residents from undeserved Hertfordshire communities, particularly those furthest from employment, and offers supported entry-level roles with structured, transparent progressions pathways. Critically, this is not about filling vacancies with cheaper labor. It is about offering genuine career ladders into clinical and senior roles, ensuring pay parity with NHS agenda for change branding from day one, liking the CPD as a structural entitlement, so development is amended. It's not an optional. So, and the last one I would like to say is addressing health inequalities by improving health outcomes in the communities from which we recruit. Is that answer your question?
Ahmad, are you there?
Yeah.
I see you in the healthcare sector as the boss. So I think I'll ask you a question. It said, what if the staff burnout a critical issue in healthcare? Why is staff burnout a critical issue?
Yeah, staff burnout is a critical issue in healthcare because it affects both workers and patients. When healthcare staff and burnout are they feel exotic stress and less worries, they can lead the mistake which puts patient safety at risk. Burnout also reduce empathy, so patient may receive improper quality care. It's also cost staff the time of the leave their jobs, creating staff storage. This increase pressure on worker, making burnout only worse. In short, burnout is serious because it's harm patient, reduce care quality, and weaken the healthcare system. That is my answer. You, if you are satisfied, or I just tell more.
That's lovely. If anybody have any other question, they can ask because we need to nip it in the bud in Hertfordshire. What do you think, Monica?
Okay, Ejiofor, I have a question for Sunita.
Oh,
So
okay.
shall I
That's
proceed
good.
with it?
Yeah.
Yeah, go ahead.
So the question for you is, given the current workforce shortages in primary care, how can your strategies be implemented without adding more pressure on staffs?
It focuses in reducing pressure, not adding to it. This is done by improving integration so patients are treated in the right setting, using digital tools to increase efficiency, and supporting staff through well-being and retention strategies. Changes would be also introduced gradually with ongoing staff engagement to ensure they are manageable and sustainable. You got that?
Yeah. That was
Yeah.
very insightful, Sunita. I have one last question for Ahmed. So,
Yes, please.
what is the one major impact of primary healthcare shortages on communities?
One major impact of primary healthcare shortage is reduced access of care. When there are not enough doctors or nurses, people wait longer for appointments, struggle to get early treatment. This means illness can get worse before they treated, leading or poorer health outcome for the whole community. That's it.
Yeah, thank you, Ahmed.
Thank you.
Sorry again, I have the very last question to Sunita. Can I ask you a question, Sunita?
Yes, please.
How can we ensure that improving integration between services actually leads to better patients' outcomes rather than just shifting pressure between departments?
So that's a key concern. Integration has to be patient focused, not just organizational. This means designing clear care pathways, improving communication between services, and using data to track outcomes. If done efficiently, integration reduces duplication, improves continuity of care, and ensures patients receive the right care at the right time rather than simply shifting pressure elsewhere. Thank
Yeah,
you.
that
Did it answer?
sounds correct. Yeah, thank you.